Okay, so thanks again, and thanks Manos for putting this this focus onto the schedule as well, because I think it's a pathology that's very rare, but just putting it on the program of the conference makes us aware that it does exist, and that we should think about it when we are in our clinic. And that's probably the biggest message that I want to give today, that if you got patients in your clinic, that it should be in your head that it does exist and that you can do something about it. So my interest came in the nerve when I was working with Bruno Toussaint in Annecy. It's 2004, Bruno, it's very long ago. So that's where I get my interest in the nerve. And I'm not going to go into all this theoretical stuff, because I think most of us know what happens when the nerve is locked into the shoulder. We got the atrophy and stuff like that. But Manos asked me to go really into more specific practical tips and tricks. So I'm not going to go into the setup of all this, and I'll skip this because of the time schedule. And we just go to the practical stuff and the tips and tricks. Once you decided to take a patient to surgery, what we do and how we do it. So I hope I can show you this, just going over all theoretical parts. And that's where we are. So I hope the pointer is working. Sometimes it works. Okay. So this is our setup. I showed this in the afternoon already. We put all our patients in beach chair for all the procedures that we do arthroscopically. So also for the nerve releases, we use a classical posterior portal, classical lateral portal, and some extra portals, which I'll show you and point it out to you. So this is a classical posterior portal, lateral portal, and we sign the shoulder every time we do a shoulder arthroscopy. We make a drawing just to change that 2D image on the screen into the 3D as it is really live. So make a drawing, it makes your orientation easier doing the surgery. So when we make the posterior portal, we just make a tiny stab incision of the skin. We don't go all the way through the capsule, just tiny skin incision. And then we perforate the soft tissues in the capsule with the trocar. And that way it seals very nicely around the trocar, making sure there's no water pouring out, seals the water inside the joint, and makes it not getting too swollen at the end of the surgery. One remark I made here as well, no cannulas. We never work with cannulas for any procedure, but mainly for this as well. We need the freedom of our instruments to go all the way around. And once you put cannulas in, of course, you've got an easy access, but it limits your working space inside the joint. So try to use no cannulas, especially for this procedure. Okay. How do we start? Most important, we need some landmarks to go for the nerve. So in the beginning, we need to do a complete bursectomy. We have to have a good visualization of the AC joint, and we have to see the muscle belly of supraspinalis. And I'll use some videos, 2 cases, one in between the other, just to show this is a right shoulder. Okay, so we're looking from the back in the right shoulder. Underneath, we've got supraspinalis. Our instruments coming from the classical lateral portal, and the acromion is nicely cleaned up, and we see it very nicely. We go a bit more medial, and we see here when I push it right there, this is the end of the clavicle, and I open the medial bursa completely. You can see here the arch of the scapula, and we see the muscle belly of supraspinalis. So we need to do a really complete bursectomy. There's no harm in doing a bursectomy. The bursa will grow again, but once we've done this, we can have a good orientation of our next step. So this is definitely the beginning of the procedure, complete bursectomy, see the acromion and the AC joint. Once we've got this, we're going to change our camera, that's what we do at least, to an extra portal, which is a kind of a posterolateral portal. And from that portal, we're going to look for the next part of the procedure. We keep our instruments from the lateral portal here, and if you want to, you can use the posterior portal just to have a hook on top of the supraspinalis. If you need to pull it a bit back to the back, it's not always necessary, but you can use that portal. Next step, once we've done this, we've seen the AC joint, is that we're going to look for the coracoclavicular ligaments. The coracoclavicular ligaments is really the highway to the nerve, because if you follow the CC ligament, which runs vertically, At the base of the coracoid, just at the medial side, is a transverse ligament that starts. So it makes one unit actually. So once you see the clavicle and you find the CC ligaments, you find it inferiorly, you end up at base of coracoid. And if you could just go medially, you push the soft tissues around, you will see the transverse ligaments. For that, it's very important, as my patient is in beach chair, to keep my camera straight. If you keep the camera straight, you cannot miss in between the different ligaments. And I'll show you a video where you can easily miss. So we just go now. Next gaze, go and look for the coracoclavicular ligaments. So we changed the camera, we're now posterolateral. The instrument is still from the lateral side. We're looking a bit more straight now here, right onto the AC joint. We see the muscle belly of supraspinatus, and we go directly to the AC, to the lateral clavicle. And if you push the soft tissues away, you can see here this ligament running from superior to inferior, and that is the CC ligament. So you just have to go very, very gently, remove soft tissues at the lateral side of the CC ligament, go a bit more medially, and no doubt there will be a ligament running from top to bottom, which is right here. I'm pushing now the muscle belly a bit away just to remove a bit of more of the soft tissues. But that is the position. We've got here the ligament running from top to bottom. Second case, this is another case, but just to show you again, looking from posterolateral, instruments come from lateral. This is our acromion. We go a bit more to the medial side, and we see the lateral clavicle right here. This is AC joint. And if you open soft tissue here, there is a ligament running from top to bottom, and this is the CC ligament. So AC joint is really the marking place. Clean off the soft tissues, and you will encounter the ligament. Here we're a bit more anterior. This is the coracoid at the front side. So we need to be in the back. We're coming from the back. This is CC. The coracoid is completely anterior. If you see the coracoid, it's a different ligament. It's the CA ligament. We need to go for the CC ligaments, not the CA ligament. And if we keep the camera straight, it runs from top to bottom. It runs vertically. So we come from posterior, stay posterior. This is the posterior side here. Don't go too anterior, but then you can miss up with the CA ligament. Now you're way too far anterior. Okay, at the medial side of the conoid ligament runs the transverse ligament. I did a small acromoplasty here just to have some space. We did a cuff repair underneath in this case because there was a small rupture. So what we do now is we go again and look for that CC ligament running from top to bottom. And if we push the soft tissues away, as I told you, at the bottom, at the insertion, at the coracoid process, the orientation of the vessels of the ligament will change. So I'll show you in a minute. We come here right at the right side. You'll see in a minute that there is a ligament running from the top to the bottom right here. It runs from top to bottom. And if we follow it and we push it, everything down, you see that one stage here, it changes from orientation. It changes from superior to inferior. It runs horizontally. And that horizontal band is already the transverse ligament. So to go and find a transverse ligament, it's not that hard. Find the CC ligament, take enough soft tissues away, and once you push everything away, the fibers change from orientation, and once they go horizontally, that is the transverse ligament, and that's the ligament we want to cut. Have you got some other landmarks we can follow? Of course, there's some arteries running around together with the nerve, and for us it's quite easy. Normally, let's say 95% of the cases, the artery runs on top of the ligament and the nerve runs underneath. There are some anatomic variations, but 95% of the cases, if we go and if we get close to the nerve, we will see this vessel, and you see it really pulsating, and this is the artery. So if you're getting close to the region where you should be, then you should encounter this artery. You see it pulsating, and that's the structure that runs right on top of the ligament. So that might definitely be helpful in finding the nerve. And then we can see if we push that artery away, so the artery is right on the left here. If with this probe we just push the artery away, we will see that underneath the artery, we've got this ligament right here, which is a transverse ligament. And underneath the ligament, we've got the nerve running right under here. So 3 levels. One level I push away. Next level is a transverse ligament, which runs here. And underneath the ligament, we've got the nerve just running there. Okay, go a bit faster. Now we need an extra portal because we need a portal for an instrument to be able to cut this transverse ligament. This is the transverse ligament. This is the G portal. It looks a bit like the Neviaser portal, but it's a bit more medial and a bit more to the back of the shoulder. Neviaser probably would be here, a bit more medial, a bit more to the back. If you put a needle right on that spot, this is where the needle will end, right on top of that ligament. We've got the artery running on top, we've got the ligament, and the nerve will be underneath that. Okay, so I'll go a bit faster. If you're able to, you can see the nerve at both sides. You can go past the ligament. This is the nerve actually in front of the ligament. Well, you can debride it, you can see it. And if you know where the nerve is in front and in the back, you feel very safe to go and cut the ligament. So I cut this video because I'm running late. And once you're there, the instrument comes from that G portal. And some ligaments are very weak and you just can actually only almost push it just with a cutter. This is the instrument that the knee surgeons use to do a meniscectomy. It's the same instrument. There are specific instruments developed to this, but I'm just using this instrument. In this case, you can see the nerve, which is already splitted before it came underneath the ligament. That's an anatomic variation. Sometimes the nerve is already split before it enters the notch. And I'll just show you another example. This is a big ligament. Actually, we've got the artery running here. We've got the nerve running underneath. This is a very big ligament with the nerve just underneath, squeezed here. And if you got a good view, the artery is pushed there. Just with the flat tissue of the instrument, you push the nerve downwards and you're very safe to cut the ligament on top. And now what we do is we resect actually all these remnants these days, making sure that everything stays very nicely open. You can encounter problems. This is a bony one. If it's bony, just protect the nerve underneath. You drill it and you release the nerve like this. Of course, take off the suction of the drill. Otherwise, you can take the nerve with you. Stay careful. Just go quickly over this, just to show you final image. If there's some compression on the nerve in the back of the shoulder, just infraspinatus, it might be caused by a big cyst like here. And if you go just to the back, you push infraspinatus away, you can see the neurovascular bundle, which runs quite high. So you encounter the nerve very quickly. So you can imagine if you got a cyst like that it will press on the nerve. There's a discussion if you need to resect the cyst or just repair the labrum in those cases, but at least it's quite easy to go and look in the back of the shoulder for the infraspinatus branches. So I think I definitely need to stop here and think about it, know that it exists, and know that you can release it if necessary. Thank you.
Thank you very much. Very interesting.